to our welcome to our June idea presentation. Um, as you guys all know, if there's been any bumps along the way transitioning from Cornell and the Idea listserv and the website, the calendar invites from the Cornell side to this side, feel free to reach out to me or to Courtney Fish, who's behind the scenes magic, um, and let us know what we need to do to help fix it or help arrange things better for you all. But I think everything's running pretty smooth now. The whole listserv has transferred over to here. If people still post to the old listserv on Cornell, I just direct them to do it here so people get used to doing it. But it seems to be working and going out just fine. But if there's any problems that y'all have, please let us know and we'll correct them right away. Same thing with this link. We had sent out all the cancellations, links for the calendar invites for the Cornell and resent them out for this under the Mizzou system. So we should be okay. Obviously, there's plenty of people on this, so something must have worked right. I'm super excited to introduce Elizabeth. Came across her work through a different venue. Someone actually referred me to it because of all the talk we've been having about this. And as you guys know, what I like about this is, if you remember, IDEA started in 2020 because of this. Like, because of COVID, how did we translate what we do that makes sense, that meets best practice and quality work onto some other platform? And I think what's really cool is many of the lessons we learned from COVID. Obviously, we don't have to do a lot of it now, but we learned so many good things that we can do that it changed our models and our practice in many ways. So I wanted to introduce Elizabeth. She's going to be talking about translating best practices in autism to a telehealth platform, and has done a lot of work here, a lot of research. So I'm really anxious to hear what she says. So Elizabeth, all yours.
Well, thank you for that introduction. So I will just go through a couple of things. So I have no financial disclosures for this. So all of the research that we've done as part of this project has been pretty much part of our clinical work. So we are definitely clinical researchers, where we think about how can we take what we are doing in clinic and be able to learn about what we're doing in clinic, with the data that we're already collecting, or if there's little things that we can add to understand our processes better, and then share that with anyone else who may be interested. So I've been working here through Nationwide Children's Hospital and OSU for the last 12 years. And my focus is really on being able to improve access to services. So as we all know, access to service is something that we're constantly trying to improve as waitlists continue to balloon. And so my work is really focused on how can we use new technology, allocation of resources better to be able to get autism assessment and access to services to a broader group of families. And so my focus in the world of telehealth really began in March 2020, like many of us, as we were thinking about our own program. But for this presentation, I'm hoping to not just focus on our telehealth model, since I know that's something that this group has focused on a lot and was actually one of the big reasons that I got together to begin with. So I do want to talk a bit about what we learned through the creation of our telehealth model, but put that within the context of how we develop services more generally. So the model that we use when we're thinking about any sort of tweaks to our best practice models of taking those services, translating them into something else. How do we make sure that what we're doing is still quality services? I'll talk about the support that we were able to get for a telehealth model by using some of those clinical data sources. And then also talk about a broader study that we did, a qualitative study, looking at what providers across the country were doing and what they learned from this rapid transition to a brand new technology, doing the services that we know we do well in a completely different setting. And then I want to talk a little bit about some of the changes that we've made to our broader model based on what we've learned through this rapid transition in services. So as I'm sure this group is already well aware of, there is definitely a crisis for access of services for children who are concerned about having autism spectrum disorder. So many of our families are waiting years, even when very initial concerns are coming out at very young ages, they still are often having to wait years to get that final diagnosis and be able to move on to finally accessing the services that they'd like to access. And those delays tend to be greater for certain populations, including those with fewer resources, those from more rural areas, and those from underrepresented ethnic and racial groups. And so we know that doing what we're doing right now is never going to be enough to get services to every single child. And so we have to continue to innovate in how we use our resources, how we get the most needed services to children as they need them, to be able to access what they want to do for next steps, to be able to, and many of them getting a diagnosis is one of the key components to being able to access those next steps. And so for our center in particular, we are focusing on having a comprehensive model that has several pathways or several flexible pieces that we can use to best allocate resources to families in order to be able to increase access for anyone who wants an assessment for autism spectrum disorder within our catchment area, which is pretty big. So we see the majority of Ohio, as well as many families from Kentucky and West Virginia. And so we want to make sure every family who wants to come to see us is able to, but also to be able to make sure that we're giving them quality services that are individualized to give them what they need at that moment to move on to the next steps. And so when we're thinking about taking what we're already doing and translating into a different part, so how are we making this model more flexible? We want to make sure that the new services we're creating are going to continue to do what we want them to do. And so we've created this model that has 5 steps that we think about whenever we're introducing a new service line or tweaking a service line we've already created into a new technology. So we want our services to be effective, meaning it's doing what we want it to do. So we're seeing the families who need the service. We're providing care for everyone who needs it. The care we're providing is being able to result in the diagnoses we want it to be able to, into a report that we want it to be able to. And we also want to make sure that those services are acceptable to everyone who is going to be accessing them. So that means the clinicians that are providing care, families who are receiving care, but also all of the different community partners that are playing a role in receiving the services that we're giving. So who's going to be getting that report afterwards? So our schools, our intervention places, our community partners, like we have a developmental disability resources by county. And so those service coordinators need to be getting a report that they can use. And also to make sure that what the services that we're providing are going to be acceptable to the insurance companies that are paying for the services that we are providing. And then we want those services to be comparable in quality. So are we using what we know about existing best practices? How are we going to use that to translate into something new? As well as to be feasible. So do we have the resources to do what we want to do? Do we have the personnel? Do we have the space? Do we have the technology? If we're introducing new technology or new materials, are families able to access that technology easily? Are clinicians able to access that technology? Are we adding any additional burden onto our families as we're doing something new? So we want to be thinking about all of that as we're translating as well. And then finally, we want to make sure that the services we're creating are feeding into our larger model to make sure that they're equitable. So we're getting the services to all of the kids who need our services. So that's for us is across the age spans, typically starting at about 18 months all the way up to 18 years old, but also making sure we're not leaving any of our groups out. So those from different racial or ethnic backgrounds, those from different resource levels, those from different geographical areas. We want to make sure that even though a certain service line or a certain model might be focusing on a specific group, that larger model continues to provide the care we need to all the people who need it. And so telehealth for us has really become part of our broader model. So we see telehealth as one tool within a comprehensive model. And the reason for that is not necessarily that telehealth is increasing our capacity. So it turns out that it doesn't necessarily save on that time and personnel resource, but what it does do is give us an opportunity to provide services to people that may struggle accessing those services in clinic. So certainly barriers that we think about, like transportation difficulties or being located very far from the clinic. So many of our families are driving hours to come see us. And so any way that we can cut down on that travel time or make it easier to get services without having to travel all that way to our clinic. As well as we realized that being able to have telehealth options for various appointments means that families often have to miss less time from work. I've done plenty of feedbacks from in cars, not while people are driving, but on lunch breaks, in offices as people are, taking some time off or before work, right after work. As well as decreased need for childcare for other children, as other children can be busy in the house while families are doing appointments. And overall, this has been a great way of helping some of our families that really have a lot of stress of getting into the appointments in clinic. So many of our kids really struggle with leaving their home, going to a new place. Many of our children are medically fragile. And so being able to do an appointment from home really reduces stress for families. Having a telehealth option within our broader model also increases our agility. So certainly during times of crisis, we've learned now having this model will help if we ever run into a similar situation where we're completely shutting down our services. But we've even found it to be really helpful during times where lots of our people are out or ill, or lots of our families are getting sick. When we have one child that's sick, we can still see the other child if we can do everything by telehealth. So it's really increased our agility along with overcoming some of those barriers for our families. And as we got into thinking about translating our own model to telehealth, we learned a lot that telehealth is not new, even though it was very new to us, that these models had been around for quite a while, or these services had been around for quite a while, people accessing technology this way. And so there were quite a few studies that had been looking at using telehealth technology to provide intervention for families with autism spectrum disorder. So, thinking about particularly parent coaching by telehealth, they were finding it to be pretty effective in getting services out, acceptable to families and clinicians, feasible with the technology they were using. We also found that there was lots of different measures where they had compared in person to telehealth services for cognitive measures, for language measures, for academic testing, and finding it to be pretty comparable between the two modalities, at least for school age and adolescent children. And then there have been some reviews that were looking at research that was done before the COVID restrictions and that have continued past that, finding that telehealth models for autism spectrum disorder assessment are also found to be effective, comparable to those in clinic services, and acceptable to families. So just there being a lot of research support for using telehealth as a technology to complete assessment, there wasn't a lot of use of this technology. And like many of our evidence-based practices that will come out in research, getting them to actually be implemented in a wider range or in a wider capacity tends to be a really difficult transition. So we are not always the best at change. When we know what we're doing already works, we tend to be hesitant to want to change that. And so a lot of times a crisis or a reduction in access or a need for immediate change is something that can really catapult that change forward. And so certainly for us, it was that COVID pandemic gave us the motivation we needed to look into using telehealth more broadly as a technology. So we knew our wait list was already long. We didn't know how long these restrictions were going to last. And so we were faced with either shutting things down for who knows how long, to thinking about how do we take what we already know and translate it as quickly as possible into a telehealth platform. And so bringing it back to that original model, what we were thinking about is that we wanted to make sure that we could continue to work within our interdisciplinary teams to be able to provide care at the same capacity. So we didn't want to reduce capacity if possible. We wanted to keep where we were so that way we weren't adding to our wait lists. We wanted to make sure that the services we were creating were going to be acceptable, though, to especially all of our different clinicians. We wanted them to feel comfortable with the work they were doing, we wanted to make sure that they still felt like it was good work. And we also wanted to make sure our families found it acceptable, that they could use the technology, that they felt comfortable with the work that we were doing, that they also felt comfortable with the conclusions that we were drawing within this model. And then we wanted to make sure we were thinking about the product, the final product that the community partners we were working with, the insurance payers that we were working with, were also going to find our product to be acceptable. We wanted to make sure we were continuing to use standardized measures. Now we needed to tweak those a little bit, which I'll talk about, as well as thinking about using multiple sources of data. So definitely continuing our interview, our behavior observation. We wanted to include both of those parts, although we knew we'd have to switch up a little bit of how we were doing them. And we wanted to make sure that the model we were creating was feasible. So we know families were going to be going through a lot of stress just generally. And so if we were going to be having them have to do something completely new, we wanted to minimize the stress of being part of that assessment process in a different way, as well as to make sure we had the technology and that was going to be HIPAA compliant, that was going to be able to be used by all of our clinicians as smoothly as possible. And then again, we wanted to create a model that continued to allow access for all of our different families. And so one of the things that became really important to us was making sure we created a model that could go across age groups. So a lot of the initial research we were looking at was really focused on younger children. And we didn't want to just leave our older children out for these several months, especially not knowing how long we were going to have to be doing a telehealth model. And then also thinking about making sure that families of lower resources, so we use Medicaid, our Medicaid families as kind of a proxy for thinking about making sure we were including all of those families, as well as locations. So we wanted to make sure that using telehealth technology wasn't going to be leaving out people that maybe had lesser access to internet. We were worried that maybe they weren't going to have the technology, and so we wanted to be looking at the families that were going to be accessing our model to make sure we weren't leaving groups out. So for some context, this was what our interdisciplinary model looked like before COVID. So it's technically a 5 appointment process where it's not on here, but families would typically do a diagnostic intake first with one of our master's level clinicians. So those are social workers, licensed marriage and family therapists, and clinical counselors. And so they do that. And then for families where autism spectrum disorder was definitely the primary concern, they'd get triaged to our interdisciplinary diagnostic assessment. And so for that model, families would come in to meet with an interdisciplinary team on the first day, where a psychologist and medical provider would do an interview, while a psychometrician would do the ADOS, and our speech provider would do some speech testing. Once we finished all of that, families would stay in their room. We'd go conference, come back, and if we could give an initial diagnosis that day, we would. For families where we were making that diagnosis of autism, some of those would do genetic counseling as appropriate. And then most of our families would then come back for a second appointment a week later where they do some additional testing. So for our younger kids, that would be developmental testing with a Bailey or a Mullen. For our older kids, it would be things like cognitive measures, academic measures, and any other kind of neuropsychological measures that we thought would be helpful for rounding out that assessment. Families would then come back to the clinic for a third visit for feedback, where they'd meet just with the psychologist to go in more depth on results, diagnoses, and recommendations to make sure we're coming up with a solid plan of where you're going next. And then many of our families would come back a couple weeks to a couple months later to do a care coordination appointment, where again, they'd meet back with one of our master's level clinicians to go over how's it going? What are you accessing? Are you running into any barriers accessing services? Are we forgetting anything? Have any new concerns come up? To make sure that families were continuing on. So this was a very comprehensive model, but as you can imagine, it's also a very resource intensive model, both from our side where, we're using a lot of personnel, space, time to do this model. And we are also putting a lot of burden on families. So while families get to have a very comprehensive process, they were also expected to come into our clinic 5 times before they'd finally be finished with all of their process, which again can make families feel very taken care of, but also can be a lot to get up here, especially for our families that were coming from very far away or who had more transportation burden. So we wanted to make sure as we were thinking about transitioning to telehealth that we could continue to include our gold standard pieces of that assessment model. So multiple clinicians, multiple measures, multiple sources of data, So we knew that certain things would translate easily or more easily to telehealth. So a lot of things where we were talking face to face with the parents, so interviews, feedbacks, clinical care coordination, those things we figured would translate pretty easily. We were also able to very quickly get our forms in an electronic form too. So those were getting sent out ahead of time through our electronic medical record. And that actually worked great since we didn't have to mail things back and forth. We were actually getting forms back at a greater rate. Then we also made sure that we were working even harder than typical to get previous evaluations. So school ETRs for the IEPs that where previous testing had been done, any previous evaluations through early intervention or other psychological providers to make sure that we had as much data coming into the assessment as possible. And then, of course, what we knew would translate less easy was some of those standardized behavioral observations, as well as more direct assessment of things like those cognitive, developmental, or academic skills. And so this was the telehealth model that we came up with. So again, we wanted to be comprehensive in the beginning. We wanted to make sure that as much as possible, we were following the same pattern that we had found to be really helpful within the clinic to give families the comprehensive services they needed. But we did make some pretty big changes. One of the biggest changes was that we knew we couldn't do an ADOS by telehealth. And so instead we moved to doing the ADIR interview. We stuck to primarily the algorithm questions, but even for our older kids, that was meaning a much longer interview. And so what we decided to do was pull that psychology only appointment first, where we would do the ADI with our families. And that allowed us not only to get the space and time to do that interview, but also to gather a lot of information that would help structure the behavioral observation during the next section. So we were able to see what is very clear, both from meeting the child, meeting the parent, that are some very clear concerns versus what are we haven't yet been able to see that we want to see during a behavioral observation. We would often start with an informal observation during that interview process as well, where we'd have our psychometricians basically we flip the camera forward, be watching for our younger kids, watching them play. For our older kids, they'd be part of the interview where we were taking some observations from that. During that second day, we created a space within our assessment that we called the AVABO. We love acronyms. So this was our adapted virtual autism behavioral observation. And we thought of this as a space going in because we knew different measures were going to come out that would be able to be put into this space as we saw fit. In the beginning, though, since we didn't have a great measure, especially for our older kids, that wasn't going to require us sending a lot of materials ahead of time, we created observation protocols that were basically standardized observation tasks that we would walk parents through, walk children through, that would allow us to collect the information we needed to complete a CARS, as well as to think through those diagnostic criteria. And the cool thing about doing it this way is the whole team got to be part of that behavior observation. So everyone, we were all teamsing together to talk about, like try this or do this together. And it really gave us a different view of the child that we were looking at since we all got to see them doing all these different tasks together. Like with our other model, we'd put families in a virtual waiting room as we talked through what we got to see, and then would give that initial diagnosis that day if we felt like we had enough information. We still typically would do a feedback session for some of our children, particularly those who are a little bit older and had a little bit better behavior regulation. We did do some cognitive and academic testing virtually. So there's a great adaptation of the WISC. We also had a nice adaptation of the WJ that we were able to do by telehealth. Our speech provider was also able to do some of their measures using the real, and then they would also do parts of the self by telehealth as well. So we were able to get some direct testing done by telehealth, although not as much as we were used to. And then we would still typically, again, do a comprehensive feedback. And then we tweaked our care coordination to include not just care coordination, but also what we called rapid intervention and treatment integration, which was basically some initial behavioral intervention within a part model where we'd have families come in for 3 sessions to work on an immediate issue. Since we knew families were going to have a lot more difficulty connecting with services with COVID restrictions in place, we wanted to be able to give them some intervention to start immediately while we were also doing that care coordination. So to summarize, we moved from a standardized behavioral measure to a standardized interview measure looking at those autism symptoms. We did our psych only visit first to be able to gather information. We created that flexible space for an observation where we were able to get some really great data using some different observation prompts. And then we were able to use some or do some direct testing for cognitive and academic assessment by telehealth, although again, not as broadly as we were used to. And then we also had some more targeted intervention options added to our care coordination. And we were able to do this really fast. So this is something I'm really proud of that, about a week before the orders actually went into place, we were pretty sure this is happening. So we started our planning processes, started trialing our um, larger model, that Veda, and then the behavior observation protocols we wanted to use, those AVABOs. Our hospital also did a really amazing job of getting us technology very quickly. So luckily they were already in talks with Epic to get Zoom through our electronic medical record. It was supposed to be a 3-year process that got basically put down into about a week. Where they were able to get that up and going for us. So that about 14 days after we started this planning process, we were starting our first Veda with families. And then the between that day 14, day 45, those of us that worked on creating that initial model started training the rest of our group. So we had to do some ADI trainings. We had to get our group going with the model on a whole. We had to do a lot of pep talks with our group to let them know that it's going to be okay, you can do this. Did a lot of observations where we had them look at what we were doing. And so that by day 45, we were back up to our full schedule. So we had initially set 15 a week as our target. So before lockdown, we were seeing about 30 to 32 interdisciplinary diagnostic assessments a week, or at least we had them scheduled. Typically, we would see about 28 assessments a week with cancellations and no-shows. And so we were very proud that we were able to get back up to about that level of assessment across that summer. So this is the data that captures the time that we were completely telehealth. So luckily by August, we started to be able to bring some kids back in, although we kept that telehealth model going after that. And so as I said, what of our goals was to be able to use the data we were collecting to at least start to validate this model. So think about, was it doing what we expected it to do? And so one of the ways we did that was we took all of the kids we saw for IDAs the year before these COVID restrictions went into place between that March and August timeline and compared them to the kids that we saw, like the whole group that we were seeing completely by telehealth during the same time period. So from March to August in 2020. And so again, one of the things that we were worried about is, are we seeing the same group of kids? And so obviously we can't compare them one-to-one, but we were able to see about the same number of kids, certainly because of those couple weeks in March when we were getting the model ramped up. We didn't see quite as many, but we were only off by about 50 kids. And we didn't see any significant differences between the two groups based on gender, based on payer type. So we were seeing the same number of Medicaid families, and we were seeing the same number of families from rural areas as well. So there wasn't any significant difference there. We saw a slightly younger group by telehealth. And the reason for that is that the first couple weeks of transitioning to our telehealth model, we only saw kids 5 and under because we figured they would be a little bit easier. Our group felt a little bit more confident doing those assessments. And so we started there and then expanded to see older kids as we went on. Although you can see from the mean and the standard deviation, our groups were still pretty similar, even though there was a slight significant difference between them. And we got to see those kids across the age group. So we saw kids from 18 months to 18 years. The other thing we looked at was diagnosis. So again, we weren't able to compare the kids we diagnosed by telehealth directly to an in-person assessment, as the majority of them didn't come back in for an in-person assessment. But we were able to look at rates of diagnosis across those two groups and found that there wasn't a significant difference in at least the number of kids we were diagnosing with autism or ruling that diagnosis out. And so we weren't seeing that we were suddenly diagnosing way more kids or way less kids using this model. The other thing that we were really impressed with was how few kids we ended up needing to bring back for a follow-up appointment. So this was one of our other worries, is that we create this telehealth model. We wanted to make sure there was definitely going to be a capacity to bring kids back once those restrictions were lifted, because we didn't want to make anyone feel pressured on making or ruling out a diagnosis if they didn't feel like they had adequate information to do so. And so we had a plan in place for bringing kids back. We had a wait list. We had space in our schedule to be able to see those kids as soon as we could bring them back in. But only a small group needed to come back in. And we continued to do this model for the next year. We saw over 1,500 kids using our telehealth model. And this rate stayed the same, where we were only bringing between about 10 to 12% of our kids back in for a second evaluation, typically because we wanted to be able to do that more standardized ADOS measure, as well as for kids that we wanted to be able to do more cognitive or academic testing to rule out pieces like that intellectual developmental disorder and learning disorder. Um, the kids we brought back, some of the differences we noticed is they did tend to be older. So we did find that older kids tended to be a little tricky, especially when those symptoms were more mild, as well as when the cases were more complex. So when there may be other things like having a trauma history going on, those tended to be kids we wanted to bring back in where things were a little more complex. But we didn't find that biological sex was a predictor. So one of our hypotheses was that we might end up bringing back more girls than boys, since girls tend to be more mild in some of those presentations. But surprisingly, we did not find that. In once we'd been doing this for a while, so in August, we also had our interdisciplinary clinicians all complete a measure. They all completed it because I was able to stalk them and make them. But they all completed a measure anonymously, telling us what they thought about our model based on its acceptability, appropriateness, and feasibility, and found that that was pretty high across our group. We also had, unfortunately, a much smaller group of our families complete surveys after they were finished with the assessment. So we sent out surveys to all of our families, but the rate of return was not great. But 86% of the families that did return that survey found the experience to be good to excellent within that telehealth piece. And then we did one other small study looking at the DP4. So we use the DP4 as a quick estimate of cognitive functioning, especially for our younger kids that we were seeing through this telehealth model. So we wanted to understand, how does the DP4, since we used it previously, but we were using it a lot during telehealth, how is that comparing to the Bailey? And luckily, we have a ton of archival data where we were able to pull a subset of families who had completed both the DP4 and the Bailey from the data we already had, where we were able to look at a population that did, of course, skew heavily towards autism spectrum disorder, since that's one of the main diagnoses we're looking at, but also had a pretty decent sample of children who didn't have that diagnosis, and found that those measures were pretty significantly correlated. And we were finding that the cutoff of 69 on the DP4 cognitive was pretty similar to a cutoff of 70. So if you had a cutoff of 69 or lower for the DP4, you were also tended to be at a 70 or lower for the Bailey. So it was a pretty good estimate of cognitive functioning in our younger kids. And this will become important as I talk about some of our carryover into the future of our model. So when we think about those initial outcomes, what we were finding is that we had a model that was acceptable to our clinicians and families. We also were finding that we did a lot of work with our local schools and other community providers to talk them through the model that we were doing and how it compared to our other models, so that they would feel comfortable taking those reports. And luckily, there was a lot of relaxation in policies, regulation, rules around telehealth within our insurance companies. Certainly that's something we're now having to advocate a lot for as we're moving forward. But at that time, we didn't have to worry about the acceptability there. Although having the ADI in there has been really helpful for continuing to have our telehealth services be accepted by our insurance companies and other community providers. We also found that this model was comparable to what we were doing in person. We were able to continue to include standardized measures. We were able to continue to include both an interview and observation model, or measures. And then we were able to collect a lot of different sources of data. We continued to see equitable samples. So we were seeing kids across ages, across payer source, across geographical location and gender, a very similar population to what we had been seeing in clinic. Um, and then we also were able to achieve our goal of continuing our interdisciplinary diagnostic assessments at a pretty near typical rate, with only 11% of kids needing a follow-up in clinic afterwards. So transitioning a bit, we were also really interested as we were coming out of telehealth times and starting to transition back into our in-clinic world. We know we had learned a lot from doing telehealth services, and we were also interested to learn about others' experiences. So we were able to partner with other members of the Autism Care Network to do a qualitative study where we interviewed 35 cross-disciplinary members from 17 sites that are part of the Autism Care Network. And we asked them about all the changes they had made during COVID restrictions, but really focused on telehealth adaptations. And so I'll summarize some of what we learned with that study. So we learned that generally the sites found their telehealth assessment models to be pretty effective. Certainly confidence in diagnosis varied, but tended to lean towards positive. So most clinicians were pretty happy with the work that they were doing, although there were a couple that were very much against it. And as I'll talk about a little bit later, as I talk about factors why, institutional support played a huge role into whether clinicians were happy with the work that they were doing. Most felt they were able to make final diagnoses in the majority of cases. Although most centers also had a clear plan for assessment if we felt like telehealth wasn't working. And this was something that I heard across lots of different providers. And as we continue to revamp our assessment model, something that continues to be important is that if you're going to be cutting down on the number of assessments you're doing, for most kids, there still has to be a pathway for if you aren't able to gather enough information with what you're doing to bring kids back for a more comprehensive assessment. And that really reduces the pressure people feel in making a diagnosis without having that right amount of information, as well as helps families feel a lot more comfortable with the process. If they know that if this isn't working, we can bring you back and do it a different way, has helped a lot of our families feel more comfortable with both this telehealth model as well as other changes that we've made to our diagnostic model. The other thing that clinicians noted is that those kids that were difficult by telehealth also happened to be the kids that were difficult in person as well. So it wasn't just the telehealth platform, but it just turns out that when you're a kid whose symptoms are more mild or you have a more complex clinical presentation, or there are other factors that are making it more difficult to get through some of these standardized measures, that's going to make diagnoses difficult no matter what type of platform we're looking at. But that really lets us know that these are kids that need those more comprehensive measures, more well-supported measures to look at those symptoms. Similar to what we found in our clinic, most agreed that things that we could do directly with parents translated really easily to telehealth. So interviews, feedbacks, most people noticed really no changes in rapport. Behavior observations was definitely the thing everyone found more challenging, which I'll talk about a little bit more in detail in a minute. And there was pretty limited data on how people felt about the cognitive and other testing, as very few sites attempted it. Those that did felt that what they had worked well, but only for a very small group of children. So again, those were a little bit older, those with fewer behavior concerns, where we could manage that behavior more effectively without having to be in the room with that child. As far as the telehealth behavior observation itself went, what we found is that there were some definite strengths noted. So certainly being able to be in the home with families was really cool in many situations, not only to be able to see a different subset of behavior, but also to be able to understand that family better. So when you're in their living room, seeing what's around, seeing who's around, you get a sense of what life is like. And so it may change even how you talk about the diagnosis, how you talk about recommendations, being able to understand that family a little bit more. It also gives us a very unique opportunity to see different behaviors that we might not be able to see in clinic. So we particularly noted for our more more anxious children, they tended to interact more than when they were in their home environment. And this tends to be an area where we continue to use our telehealth tools. So when we have a child who is much more difficult to kind of warm up in clinic, we may also do an observation by telehealth to be able to see them in an environment where they feel more comfortable. It also allows us to see unique interests where, we don't have the particular materials for that child's restricted interest or a particular routine, that we're able to see it at home can be really illuminating to understand that behavior a little bit better. And then many clinicians really noted that the partnership with families was different, being able to have them as really part of the assessment. So not just watching, but actually part of the administration felt different. We were really able to strengthen that partnership, and you're seeing exactly what I'm seeing. You're seeing how hard this is or how easy that is to get these different behaviors, and parents really feeling like you got a good observation of their child because they were part of that observation. There were also a lot of challenges noted, so certainly a lot of worries about reliability. So we're still really working to understand how these telehealth measures compare to some of our in-clinic measures. And no matter what, when you're doing something by home, you're going to have less control. So even if you're sending materials home, they still might not all make it. They might not all be there. And there's going to be other environmental distractors. You cannot control the environment in the same way at home. And this had to be something, again, a lot of other clinicians noted, but our group did as well, is that you have to be able to let that control go a little bit. So you still work to do some standardization between different prompts, different activities, but giving up some of that control and leaning in more to that naturalistic observation is the only way that this is going to work. Because you just cannot get the same level of control in that home environment, especially on the scale that we were trying to do this on. And then there's just less information available in general about how social interactions vary by telehealth. So certainly this came in more play with some of our older kids where we're doing more interviewing with them. We found that it was very important to include not only an interview with them, but also watching them interact with their family at home, because that gave us often a better insight into some of their nonverbal behavior than trying to do it by video, since obviously things like eye contact and even gestures, facial expressions, all of that's a lot harder to pick up on by video. Some of what we learned also applies to just change in general. So certainly clinicians noted some different factors that made it easier to start this process. Some of them were individual. So a lot of clinicians did work trying to learn more about what was available by telehealth. There was a lot of great trainings and webinars put on during this time. Different places were allowing you to come in and observe what they were doing. Clinicians also noted that having some previous experience with parent coaching, such as through PCIT, was really helpful, being able to translate into coaching parents through a behavior observation. And unsurprisingly, those that were more comfortable with change, who got excited about new technology, who got excited about doing something new, found this transition to be easier than those where change was a little bit more difficult. But across the board, for those that were doing this new model, who were really loving it, the thing they noted the most was that trying it was the absolute most important thing. Which seems kind of straightforward, but is such an important thing to keep in mind, that a lot of times things can seem so uncomfortable or impossible until we actually try it. So that's something that we really embrace at our center, is that a lot of times we are building our bicycles as we're riding them. And we find that we don't know whether something's going to work until we start trying it, working with our families, seeing how it works to work with different combinations of providers together, doing different parts of the assessment. And it's always interesting that once you're actually doing it, you're like, oh, this is working better than I thought it was going to, but also gives us lots of opportunity to change the measures or tweak them. And certainly being able to do this as a team is really helpful. So that was something else a lot of providers noted, was when they got to work in an interdisciplinary team, when they were trying things together, when they were being able to take opinions, see different perspectives, that was making this process much easier to try something new. And as I mentioned, institutional support was also a huge key to a successful transition. So providers that reported being much happier with their transition to a telehealth platform also tended to be providers that came from institutions that supported innovation, so that encouraged clinicians to try anything, like, let's get this moving. We're supporting you no matter how you want to do this, versus institutions that were more cautious about not wanting to do anything new without really understanding everything, as well as obviously institutions that struggled with getting connected with technology or were less interested in trying telehealth options. It's much harder to get telehealth options going. We also found a key was also how much administrative support institutions could give too for trying something new. So, were front desk staff able to help with helping families understand what telehealth would look like, getting them connected with the technology. We had a great technology support system where that we could send families to if they were having any difficulty connecting. Um, and then a lot of clarity around communication of changes helped. So clinician stress was also a big piece of this, is that if clinicians felt more supported by their institution, if they felt more support managing their own stress, trying something new, changing was also easier. So as we think about moving forward, and as we were ending having to do telehealth, we realized we wanted to keep this as a tool for us. So one important piece for us was thinking about how do we triage this, since we're not going to be doing it for all children. We were very excited to get back in clinic, to be able to use our ADOS. Families were also very excited to get back in clinic, but we knew for some families this was still going to be a really valuable tool for increasing access. And so we worked with our diagnostic clinicians to think about, how are we going to make sure the families who need this most are getting to the telehealth evaluations that we still have. And so one thing our diagnostic clinicians are often listening for is what are barriers to service access. Excuse me. And so when we're noticing barriers or transportation difficulties, located very far from clinic, medical fragility, that may mean that being able to do this by telehealth would be a huge benefit to the family. Those are families that our diagnostic clinicians will talk about telehealth. Now, we still leave it up to families as far as whether they would prefer telehealth versus in-clinic services. So even some of our families we really think could benefit from telehealth will still choose in-clinic. But we've also got pretty good of helping families understand what telehealth could look like, as well as, again, making sure they understand that if it does not work, you'll be able to come back in for an evaluation in session or in clinic. And then we also do think a bit about clinical presentations. So certainly, again, when symptoms feel a lot more mild or there's a more complex presentation, we may choose not to do telehealth. And we continue to have our plan for when telehealth doesn't work. We've also continued to work more at a leadership level for continuing to make sure that we're establishing standards of practice for telehealth. So we're using these tools ethically. We're continuing our own training. So we're understanding how telehealth's changing. We're making sure we're understanding new knowledge that's coming out. All of our providers have become SIPAC licensed, so we can continue to see families from across state lines when, since licensing things that were relaxed, started to become back online. And then we also have continued to advocate with our insurance payers and our community partners to make sure that now that, again, we don't have to be doing telehealth, what we're doing is still in line with their policies, rules, and procedures as well. And so for our telehealth model, using the data we were able to collect, we did find that our telehealth assessment model was effective. We were able to see the kids we wanted to see. It's comparable to what we're doing in service. No, it's not for everyone. So it's going to be one tool within our comprehensive model. So there are definitely kids we want to bring in and we want to see them in person. We want to do an ADOS with them. We want to be able to do more cognitive or other testing with them. And then it's also feasible. So families were able to access the technology. They felt comfortable with it. We felt comfortable with it. We chose measures that needed very few materials. We were able to help families gather those materials in their homes. We didn't have to mail things back and forth. We also found that the services were acceptable to our families and our clinicians, and that we were able to see the same types of kids. So we were able to see kids across ages. We were able to see kids across resource levels, across rural areas versus non-rural areas. Um, and then very quickly, I just want to talk about this next piece because this is where I think we're really headed to the future, where we've really understood that telehealth has been able to help us really decrease burden on family by we've continued to use it almost exclusively for our diagnostic intakes, our feedback sessions, our care coordinations, and now a lot of our parent training interventions continue to be by telehealth. This has allowed us to save families a lot of time coming into clinic to do these appointments, as well as to be able to increase or decrease our own space needs. So a lot of our master's level clinicians now rotate in the office. So we've been able to hire more of them to be able to increase our capacity to see appointments. We also realized that not all our IDAs need a follow-up appointment. So a lot of our community partners have either done testing ahead of time or will do testing after, whether or not we do a Bailey or Mullen, whether or not we do other sorts of measures, they're going to do their own testing. And so if we're able to use their testing or at least send them on, make sure they're getting where they need to go, use measures like our DP4 to get us quick estimates of families that we want to really push to go get additional testing. We don't need to do that IDA follow-up. And as a result, we've been able to double our capacity for assessment. And then finally, we're able to kind of realize throughout this process, we don't need an ADOS for every eval. So there are many kids that we see that through these less standardized observations with our more standardized interview, we're able to get the information we need. And so now I'm part of a process that's trialing a 90-minute evaluation where we're seeing kids at the intake. So I'm working and other of our psychologists are working with our master's level clinicians to complete the entire evaluation in one appointment for our young kids to get them done, going, decrease their wait time by 6 to 7 months, as well as increase our capacity to see kids who need the more comprehensive evaluation in those other evaluation slots. So we know best practice changes over time. What families need from diagnostic evaluations changes as the broader culture, our broader world's understanding, knowledge about autism changes, as our services change, what families need from an evaluation changes. And we are continuing to see more and more families who need these evaluations. And so we need to continue to change our models in order to stay up with that and try to get all of our services to all the families who need them to get them to those next steps. Yeah. Some resources in here, if families are, that would be beneficial. Thank all my team who is part of this. And just a heads up, if you want to learn more about the exact model we're doing, we do a free echo training as part of our team here. And then I also really love this telehealth.org website for learning about the changing rules and regulations regarding telehealth. So I often get lots of questions about insurance reimbursement or how rules and policies are changing. And they vary a lot by state, by payer. So this model gives you lots of good, or this website gives you lots of good information for by state. So sorry, I know I went very late, but I'm here for questions.
No, I appreciate it. Thank you so much. Lots of information. I love it because I think we're hearing a consistency in the field about the direction we're going, and people like yourself are doing the hard work of, the actual evidence and publishing on it does work and why does it work and how does it work. So really appreciate it. We do have two questions I want to try to get to before we stop. Rachel asked you may have said this, but how long were each of the televisits?
That's a really great question. So the first one to do the ADI was typically about 90 minutes, and then the follow-up visit could really vary. So for our younger kids, it tended to be about an hour or two. For our older kids, it could go up to 3 hours. So that's something that we changed a lot as we moved through this process. So by the end of doing telehealth for our younger kids, we were doing everything in one appointment, and that was typically about 2 hours. But our older kids, we really did struggle with making that assessment shorter. So that's why I was saying telehealth didn't necessarily save us on time and resources, but could increase access for families that could struggle to get to us.
Thanks. And Janice had asked, we're all driven by billing and money. How do you bill for this? Can you talk about the billing aspect rather quickly?
Yeah, so as I said, I can talk about what we do, but That is going to vary a lot by your clinic, hospital, state. So I do really recommend that resource I gave you. Gives you some really good understanding of things to consider for your own state, own area. But we use the GT service code. So we bill all of our testing. And I mean, we build basically the same codes we would for our assessment. We just use, there's this modification code we use that switches it to telehealth. So far, we've been getting pretty decent reimbursement from this. I know that's something that's actually going to be changing this year in particular. At the end of the year, a lot of insurance companies' coverage of telehealth expires. So we'll see if we can continue to get them to renew that. And unfortunately, the other thing we have been running into more recently is being reimbursed at a lower rate. So we're still being reimbursed, but at a lesser rate. So that's something we're continuing to advocate for.
So, does anyone else? Well, we have about maybe 3 minutes. So, for behavioral observation, did y'all use your own structure protocol, or did you use some of the TLSDPs?
Yeah, so for our younger and older children, so when we think about the, or I should say younger, kind of school age children, so 6 and up, and then for our older children, we had two different observation protocols that we did that had a set of standardized, as much as possible, activities that we would do. So for our younger kids, it was really based around a play activity that we did very different tasks between. And then for our older kids, it was based on some different conversational prompts and activities like charades that we would do with kids to pull for different behaviors. I'm happy to share those protocols if anyone wants them. You can reach out to me and I can share them with you so you can see what we did. And then we used the observations we collected to complete a CARS along with the information we were collecting through the interview. And then for our youngest kids, we adapted a model called the ADEC, which is the Autism Detect in Early Childhood. So it's very similar to the tele-ASDPs, where it's a secondary screener that's pretty easily translated into parent directed prompts. So we were able to coach parents on doing those. And that we validated through another study that I just couldn't figure out how to mush into this presentation. So
Yeah.
is out there as well.
I know one of the challenges for all of us have been the older kids. The older they get, there's not a whole lot of evidence-based measures over telehealth to use, unlike the younger kids on the cars, and how do you create something that's standardized? So
Yeah.
thank you so much. Please do me a favor though. I don't mean to put you on the spot, but if you would send an email out to the Idea listserv with
Yeah,
a link to your paper and some of these resources, so we all have those, that would be fantastic.
of
So
course.
um, want to mention next month we have Dr. Andy Shi coming. He is the Chief Science Officer for Autism Speaks, been doing it for a long time, been all around the world. I kind of left it open for him what to talk about, especially with the world the way it is right now and kind of his thoughts. And he's a great speaker and just an amazing kind of individual and a big mover and shaker in autism. So make sure you join us next month and listen to Andy. Kind of excited as well about the week after that, or the month after that, we have Dr. Amy Essler coming to talk about the prevalence numbers for the first half of it. And then the second half of it, we're going to have Helen Tager-Flassberg come. She is the founder and driver, main coordinator of the coalition of scientists that are the main force right now responding back in an academic and direct way to all that's happening in our world with RFK and all this stuff. So I'm really curious what she's going to talk about during that last half hour. But I know this is something that we all have thought deeply about and are worried about. So she should be interesting to listen to as well. So again, Elizabeth, thank you so much for your time. And guys, stay cool out there. I know it's like 145,000 degrees outside. So please stay safe. Right. Bye, everybody.